Okay, you're live and recording.
Thank you. All righty, thank you. This is the Washington Academy of General Dentistry Stay Home, Stay Healthy CE webinar series. This is our third webinar of the day, and we've just opened it up, the webinar. So we've got people streaming in. We're already up to over 300 participants. We expect we'll have probably 1,100 based on the registrations for this afternoon's guest speaker, Dr. Taiseer Sulaiman. Everybody, you're going to enjoy this presentation. This man knows more about dental materials than anybody I know. We'd like to thank all our co-sponsors, the Canadian Academy of Restorative Dentistry and Prosthodontics, University of Washington School of Dentistry, CE, the Dental Society, Seattle King County Dental Society, Snohomish County Dental Society, and Pierce County Dental Society. We'd like to thank Patterson Dental and Comet USA for their support. Today's presentation, you will receive CE credit. You will receive CE credit to the email address you registered at. That should be coming in the next few days from the University of Washington School of Dentistry CE department. So be looking for an email from them. You'll get a PDF. Save that PDF just in case you need it for your records down the road. AGD members, we are going to submit your CE credits directly to the Academy of General Dentistry, so you won't need to do that, but that won't show up on your transcript for probably 2 to 4 weeks from now. So just give it a little bit of time. We ask you to be patient. For dental students out there, we appreciate you joining us today. This program is co-sponsored by the University of Washington School of Dentistry AGD Student Chapter. For those of you that were with us with Janice Hurley and want to share that webinar with your staff members, that will be on YouTube within the next couple of days. Yes, today's program is being recorded. It will be available on YouTube for a period of time for you to share with your staff members, your colleagues, etc. And speaking of colleagues, feel free to invite anybody to attend these CE events. You do not need to be an AGD member. Anybody is welcome, hygienists, assistants, front desk staff, you name it. We're happy to have you. If you are interested in any of the CE events that are going by on your screen there, either use the QR code or you can go to www.washingtonagd.org and you'll be able to register for these seminars. Some of them are not on the website yet. We're putting them up as quick as we can. We're kind of a small volunteer force here, consisting of our executive director, Valerie Bartoli, and our panelist, Dr. Gary Hayamoto, and myself, and Dr. Pressett, who's handling the WAGD website registration, uplinks, etc. As you can see, we have a great lineup of speakers. Many of these speakers, you know, get paid very good honorariums to go out and do this stuff. Every single one of our speakers, our presenters, are doing this pro bono, free, out of support of all of you that have supported them over the years. And we thank them for it. We couldn't do this without that generous support. And we couldn't do this without the generous support of our sponsors as well. Getting the word out, for instance, the Arkansas Academy of General Dentistry, the California Academy of General Dentistry, Texas Academy of General Dentistry. Hey, any of you AGDs out there can feel free to send the information to your constituents. Please come and see us on Facebook at Washington Academy of General Dentistry, or look for us on YouTube. Remember to like and subscribe on the videos, and feel free to share those videos with your colleagues as well. Just going to take a look at our numbers coming in here. Yeah, we're still ticking up at a fast pace. So some of you might be new to Zoom. Just kind of explore the interface here. Move your cursor around. You can see you have different options for viewing either the panelists or the speaker view. When the presentation is up, you'll have Dr. Sulaiman off onto the right-hand side probably, and his PowerPoint presentation in the middle there. So you can't hurt this thing. If for some reason you get knocked off, just log back in and you'll be good to go. You can see some of these webinars have already passed here today. We just wanted to leave those up just in case you see something that's interesting there and you want to log into YouTube and watch those webinars. Those webinars are not up yet. They will be in the next day or so. So check back. And tomorrow, we have a great lineup again, and you won't want to miss Dr. Fling. He's currently sitting at the side of the road in Oklahoma with a blown out tire on his motorcycle. So if anybody's in Oklahoma City there and can give him a ride home, that would be helpful. All right, Dr. Michael Giardino is going to review the new perio classification system for peri-implant disease and periodontal disease tomorrow. That's one that I've seen at the university. He's a grad student in our perio program, and he really does a nice job breaking that down. Don't forget, we've got Dr. Nash and his wife, Deborah, is presenting tomorrow for us as well. Terry Harris is going to be back with us April 28th and doing his infection control checklist. So those of you that know Harris Biomedical know that he produces great information. Looking forward to meeting Penny Reed. Recommendation from all our friends like Judy Kay and Janice Hurley and Lois Banta. So thank you for everybody that's sending speakers our way. Okay. Looks like we're just about up to our total registered participants. So with that, I'd like to say welcome to the WAGD Stay Home, Stay Healthy CE series. This series is co-sponsored by the University of Washington School of Dentistry CE, the Canadian Academy of Restorative Dentistry and Prosthodontics, Comet USA Patterson, Seattle King County Dental Society, Pierce County Dental Society, Snohomish County Dental Society. Thank you, everybody, for your support here. Before I introduce today's speaker, he's a good friend of mine. I just want to remind you that all the CE is coming to you for free. One of the benefits of membership in the AGD, for you young dentists out there, you dental students, when you graduate, membership in the AGD is only $78 a year. So there's a very low bar to getting hooked up with this great continuing education. Again, look for us on YouTube. And with that, I'd like to introduce today's speaker. I just want to emphasize that today's speaker is not sponsored by any of our participants out there. He is doing his work on his own there at the University of North Carolina. And we really thank him for his knowledge and sharing that with us today. Dr. Taiseer Sulaiman is the Director of the Advanced Operative Dentistry and Biomaterials Research at the University of North Carolina, Chapel Hill, where he gained his clinical certificate in operative dentistry and completed his PhD in dental materials from the Department of Prosthetic Dentistry and Biomaterial Sciences from the University of Turku in Finland, in collaboration with the Department of Operative Dentistry, University of North Carolina. Dr. Sulaiman is a clinician, a researcher, hoping to bridge gaps between dental research and clinical application. Dr. Sulaiman's research focuses on dental ceramics, adhesions, cements, color, and appearance in dentistry and biomimetics. He is a member of numerous academies, including the International Academy of Dental Research, the American Academy of Dental Research, Academy of Operative Dentistry, the Society of Color and Appearance in Dentistry, and the American Dental Association. He has lectured on numerous national and international stages and serves as a reviewer for many peer-reviewed dental journals. You know, it gives me great pleasure to welcome our friend, my personal friend and friend to the Washington Academy of General Dentistry, Dr. Taiseer Sulaiman. With that,
Thank
sir,
you
I'm
very
going to
much.
stop sharing my screen and welcome.
Thank you. Thank you very much, Dr. Hess. It is an absolute pleasure to be here with all of you. And I wish that everyone is healthy and safe. And really warm greetings to all the participants in the webinar today. Thank you very much for having me, Dr. Hess. It's an absolute pleasure. All right, so I'm just going to go ahead and get started here. I'm going to share this.
So before you get started here today, I'm just going to mention to everybody, if you have any questions, please type them in the Q&A. And I think we'll wait till the end of the presentation to give those questions to Dr. Sulaiman. Feel free to use the chat function and say hi and good job and all that. But if you have a question, try and keep the question brief, and please put that in the Q&A section. Thank you very much.
Okay. All right. Well, again, it is a great opportunity for me actually to share with you a topic that I have relatively recently developed, and it was based off of some requests from dear friends to talk about this topic. But first and foremost, I am an assistant professor at the University of North Carolina, Adams School of Dentistry. So it is, again, a great pleasure to be here with all of you today. And we're going to talk about bleaching. And specifically, I'm going to talk about vital tooth bleaching. And so, you know, a lot of clinicians out there know what bleaching is. They know mostly know how it works. They know that there are several products that are available to us today. But really what I'm focusing on is, after understanding the mechanism of bleaching and the products that are available to us, one of the things that I really wanted to emphasize on is comparing between the different products that are available. And I think that's very important for clinicians to understand. And if you have that kind of information, I think you will be able to provide your patient with the proper guidance when it comes to this topic, because we all know that the patients come in, they want whiter teeth. This is something that has a very heavy share in the market. So therefore, I'm going to really focus your attention on some of the reviews that I will be sharing. They are reviews of clinical trials that have been conducted on this topic. However, most of these studies are funded by manufacturers, so you have to be very careful in interpreting the results. And so the element of bias is very, very high when it comes to reviewing topics or research related to bleaching. But again, I don't mean to bore you with a lot of the systematic reviews that I'm going to show, but it's very important for us to understand where these products stand and how efficient or how effective they have been over the past years. And so what I will be talking about over the next hour or so is we'll look into the mechanism of vital tooth bleaching. I'll talk about the at-home bleaching systems and the over-the-counter bleaching systems as well. We'll look into the in-office bleaching systems that are available to us. And then we'll see the effect of bleaching or bleaching products on the natural tooth structure and also on other restorative material, whether that has an effect or not. And then we'll wrap it up with some take-home messages. And you can see from the title, 30 years after really marks the remarkable introduction of at-home bleaching, supervised at-home bleaching by Haywood and Hyman back in 1989. So I think it's a milestone that we've reached to after 3 decades of using this specific technique. And that's why I kind of named the title to match that 30-year anniversary of since the publication in 1989. And so again, starting from the basics, tooth discoloration can be extrinsic or it can be intrinsic in nature. Extrinsic is mainly caused by factors such as smoking, pigments in beverages and food, antibiotics, and also metals such as iron or copper. Intrinsic tooth discoloration, it can be either genetic or caused by aging also. Antibiotics have a role in that, high level of fluoride, restorative materials can also lead to intrinsic tooth discoloration. And just out of the concept of you're having a discoloration on the tooth structure, whether it's intrinsic or extrinsic, there are whitening agents that have been introduced over the years in dentistry. These whitening agents vary from being abrasives that really involve in the mechanical removal of stains, anti-redeposition agents, which really cause the prevention of deposition of chromophores, and I'll talk about that in just a minute. Colorants, which are intended to lead to a white color. We have surfactants that have the removal of the hydrophobic compounds from the tooth surface, and proteases, degradation of proteins, peroxides, and that's going to be the prime focus of the talk today, which really, by definition, it's the oxidation of organic chromophores, okay? Chromophores, sorry. And so these are the whitening agents that have been introduced or are to our profession. But my focus is going to be on peroxides and specifically talking about hydrogen peroxide. The reported concentration that has been used in our profession is between 5% to 35%. Hydrogen peroxide is a colorless liquid. It has low molecular weight. It can penetrate dentin. It releases oxygen when it contacts water, and it breaks the double bonds of the organic and inorganic compounds. So you can see I'm just kind of putting a definition of what the hydrogen peroxide is, what we're using as a bleaching agent or whitening agent. Carbamide peroxide is also another peroxide that we have been using for bleaching, and the concentrations reported in the literature range from 10% all the way to 35%. Carbamide peroxide is a white crystalline solid. It releases oxygen when it comes into contact with water, and it breaks down into hydrogen peroxide and urea. So every time you have about a 10% carbamide peroxide, it equals 3% hydrogen peroxide and 7% urea. Okay, so that's just for you to make the calculation or do the math whenever you're looking at specific concentrations. Okay, and carbamide peroxide leads to eventually the slow release of hydrogen peroxide. Okay, so it is somewhat of a weaker version of the hydrogen peroxide. Okay. Before we get into the how bleaching works, we're dealing with a natural tooth. We're dealing with that tooth interacting with the light. So there's certain fundamentals that we have to understand so that we can appreciate this process a little bit further. So when we have an incident light that's striking the tooth structure, you can see that that light is either reflected specularly, or it is diffusely reflected. That is when you have an uneven surface and the light beam is reflecting from it, or it's transmitting through. So it's a very unique optical phenomena that happens with the tooth structure. So we know that dentin is responsible for the opacification. We know that the dentin enamel complex is responsible for transparency. And we know that enamel is responsible for the translucency, okay? And so when we look at a tooth structure, and any time we're determining the shade of that tooth structure, we always try to extract the chroma, which is highly defined in the cervical third of the tooth. Value is highly defined in the middle third of the tooth structure, and hue is very well defined in the incisal third of the tooth structure, okay? And so something very important to point out is surface texture. And you can see here with this glass slab increasing in surface roughness, what is happening is that the translucency of it is decreasing. The opacity is increasing because of the amount of light that's reflected. If you think about it, that's exactly what's happening with bleaching sometimes. When you're doing, especially in office bleaching, with high concentrations of hydrogen peroxide, that can lead to some roughening of that surface. The light reflecting from it will increase the opacity of the tooth structure. And that's why you can see that the teeth are highly opacious or less translucent and whiter when we immediately post in-office bleaching. And that's exactly what happens. So I'm trying to explain some of the things that happen to the tooth structure along this process. And also very important to keep in mind, and this has to do really with the age of the patient because it has to do with the amount of enamel. The thickness of the enamel varies. And so we have very thin enamel at the cervical region and thicker enamel towards the incisal. So the gradation or the change in color will differ from cervical to incisal. You have to keep that in mind. And what also plays a very important role is the thickness of the enamel. Younger patients will have thicker enamel, and therefore, will have more distance for the bleaching agent to penetrate versus an older patient that has a very thin enamel. The dentin, the discolored dentin, or the color of the dentin, underlying dentin, is very clearly pronounced versus a younger patient that has a thicker enamel. And so again, the only way to report this in a useful manner that a clinician can understand is to interpret the results from research. And so we have to understand whenever we're talking about color and when we're evaluating differences in color, we have to understand that there are thresholds, okay? And if a number, especially difference in color, which is referred to as delta E in the literature, if that number is beyond a specific value, for example, here, perceptibility, the delta E is around 0.8. So that means that half of the population will perceive that difference in color between the beginning and between after bleaching. And acceptability is around 1.8. So it's a little bit of a higher value. So that means your eye will definitely detect the difference in color. So all these reportings on the literature, I think clinicians have kind of stayed away from them because they really can't comprehend what's happening in terms of the research aspect of it. So I'm hoping to interpret that information to a language that clinicians can understand. So you just have to keep in mind that there are values. Whenever you see a change in color that is beyond 1.8, then you're going to realize that that change in color is significant. Versus when the number is less than that, probably your eye is going to have a hard time detecting that difference in color. And that means a lot when it comes to bleaching and bleaching research. And so one important thing to point out here is that if you are doing a bleaching case and you're monitored bleaching, you want to make sure that you're using the Vita Bleach Guide 3D Master, which is a product from Vita. The Bleach Guide, if you see the orientation of the shade tabs, they are oriented in a way that allows you to monitor progress in bleaching. And it's designated as a specific number versus a shade. Patients have a hard time explaining to them or understanding, A3 or 1M1. They really don't know. However, if you defined, like, Mrs. Jones, you were at a 15, starting our procedure. And then when we follow up with you after a few weeks, and now you've reached, and you're showing that through photography, that you've reached a 5 or a 7, it's also a very nice, useful scale to explain to the patient. And you can see the orientation of the shade tabs has been organized according to the value. And that's the most important thing when it comes to monitoring bleaching progress. And so you really need to stop using the classical Vita shade guide for monitoring bleaching. That's not meant for that purpose, okay? And it's very confusing and difficult for you to monitor. Okay, so as we understood some of the fundamentals, let's get going here a little bit on to talk about how does bleaching work, okay, first and foremost. So we have extrinsic staining, and we talked about that, and it's really accumulation of chromatogenic substances on the external tooth surface. It can be removed by routine prophylactic procedures, and it's highly responsive to bleaching, okay? That's for the extrinsic stains. Intrinsic stains, on the other hand, they result from genetic disorders such as dentogenesis imperfecta, amelogenesis imperfecta, antibiotics, caries, pulpal hemorrhage, amalgam restorations. Intrinsic staining is a lot more challenging to whiten or to bleach. So it cannot be removed by regular prophylactic procedures, and it can be reduced by bleaching agents. So I would not really guarantee any successful outcome from teeth that are intrinsically stained. It's a little bit more challenging than the extrinsic stains. But however, we have these colored compounds on the tooth that are called chromophores. And when the light strikes these chromophores, they reflect back to us a yellow or a brown wavelength. And that's why the tooth appears discolored. Okay, so that's just understanding why our teeth darken due to, like I said, food or certain beverages and certain habits. Extrinsic stains is basically when the light hits these chromophores, it reflects back a yellow-brown wavelength, and that's why they appear discolored. So when we're using hydrogen peroxide and layering it on the facial surface of the tooth, we can see here that the hydrogen peroxide is penetrating through the enamel surface, reaching to these chromophores and oxidizing them, okay, and breaking them apart. So really what is happening in essence is that when you're bleaching with hydrogen peroxide, you have oxidation of the organic chromophores to non-colored organic compounds, okay? So now they're colorless and they're reflecting, they're not reflecting the yellow or brownish, wavelengths that we used to see before. And so that's just really what's happening with the bleaching process. Now, there are certain tips or tricks to enhance the efficiency or the effectiveness of hydrogen peroxide. And one of them is simply by using a higher concentration. Now, if you're ignoring the side effects of that, that's no good really. But if you wanted to enhance, technically speaking, just up the concentration. And then you can also increase the application time. Increasing the temperature also, that exacerbates or that kind of enhances the chemical interaction that's happening, and it will promote the effectiveness of the hydrogen peroxide. The large size of the openings of the dental tubules in younger teeth. So that also leads to easier penetration and easier for the hydrogen peroxide to reach these chromophores that can be sometimes deeply embedded. And also variations in the tooth structure due to its location. Not all the teeth are the same in the arch. Sometimes teeth that have undergone certain restorations and other factors, all of these can affect the function, the effectiveness of hydrogen peroxide. Okay, penetration is improved by specific formulations and delivery systems, and we'll talk about that. You can see some manufacturers have added certain components to the hydrogen peroxide to enhance its effectiveness, and some others have introduced specific delivery systems that also can ensure the placement of hydrogen peroxide on the tooth structure. So these are the factors, or these are some of the key elements to focus on when you're using hydrogen peroxide. So now that we have understood how hydrogen peroxide works, how long does it last? And so that is a very common question, or a popular question that you will get from your patients. And so what I can share with you here is this is probably the only study that looked up to a follow-up of 2 years to see the effectiveness of at-home tooth, vital tooth bleaching. So what they used here is 10% carbamide peroxide and 16% carbamide peroxide. And so they applied it for 2 hours per day, up to 3 weeks. Now, again, so that we can understand how bleaching works, we have to understand a little bit of the science behind it. And how these researchers reported these findings is through measuring LAB values. What L stands for is value. So 100 being white and 0 being dark, okay? A, you can see, is the amount of red to green in a color, and B is the amount of yellow to blue, okay? So very simply put, so that we clinicians can understand how this is being interpreted to us, if I say that the L value was increasing, that means that the tooth is becoming whiter, okay, or lighter in color, okay? If I say that the B is decreasing, the value of B decreased before and after, that means that the tooth is becoming less yellow. Okay, if I said that the A is decreasing, that means that the tooth is becoming less red. Okay, so how can we interpret that information to their findings. So again, what they did is, if you follow my lead here, at the beginning, of course, the change in L was 0. And then at the first month, you can see that 3.5 was the amount of change for both bleaching products, the 10% carbamide peroxide and the 16%. And you can see here that the white, so yes, the teeth became whiter. And then after 6 months, you can see a slight drop, 12 months, almost at the same level. But the most important finding here is the value of the tooth after 24 months remained the same. Now, there's many factors that play into this, but the people that they enrolled into this study and they followed up with, that was quite surprising to see that, that the value of the tooth did not change over 24 months. How about the A? So like I said, when decreasing the A, the tooth is becoming less red. And you can see here that within the first month, both of them dropped. But now if we scan through the 24 months, you can see that the 16% really went back to its original value. So the tooth, if it were, it became less red at the beginning and then started gradually to going back to after 24 months. And then the 10% carbamide peroxide had a little bit better outcome here, not going back to the original redness of the tooth structure. And also, if you looked at the B, which is the amount of yellow really in the tooth, you can see within the first month, that 16% was a little bit better than that. But you can see after 24 months, the tooth did return to becoming a little bit more yellower, but the carbamide peroxide at 16% really maintained that level that is below, that is less yellow than it was before. So what we can conclude here is that the tooth shade remained lighter than at baseline for both carbamide peroxide concentration. That's in terms of lightness. But also, if we wanted to look at increasing of the A, which means redder, and B, yellower, color parameters were observed for both groups. So the tooth, in terms of value, maintained at 2 months. In terms of red and yellow, kind of went back to its original state. So that was quite interesting to share, because that's a very common question. And believe me, out there in the literature, there's not much information on it, okay? Some followed up for 6 months, some followed up for a year, but this study followed up for 2 years, which I thought was quite important to share with you all. Okay. So now that we've understood how bleaching works, we've understood how the possibility of how long it can last. And you know, when the patient asks me that question, I forgot to say, I always say it depends. There's many factors that it depends on that. You know, if the patient is a heavy coffee drinker and heavy smoker, for example, then, you know, of course, you're not going to give these promising numbers. But patients that are healthy and that are fairly moderate in terms of consumption of dark stained beverages or food, you can see that the outcome can be favorable and can last up to 2 years in terms of value of the tooth structure. And so moving along into the at-home bleaching systems and also the in-office bleaching systems. So let's take a look at the at-home bleaching systems that we have available. So we have dentist supervised products and we have over-the-counter products. So let's take a look at the dentist supervised products. So most of you know this and have actually been using it. We have the gel in trays, and these trays are custom made trays, okay? And so this was first introduced by Haywood and Hyman from UNC at 1989, and that really was the hallmark of the Night Guard Vital Bleaching. And in that publication, what they documented was that they used 10% carbamide peroxide in custom fitted trays. They were fabricated in the dentist office, and they allowed the patient to wear it for a few hours in a day up from 2 to 6 weeks. That was the recommendation that was initially introduced in 1989. And so if we wanted to look at the efficiency or the effectiveness of this and comparing hydrogen peroxide to carbamide peroxide by using these custom-made at-home bleaching trays. So this is a nice review. You can see that a lot of the clinical research that has been done using hydrogen peroxide ranged between 2.5 to 14%. The go-to concentration has been recommended at 7.5%. That's kind of the golden number you want to go to for at-home hydrogen peroxide bleaching agents. For carbamide peroxide, it's been reported as low as 5% all the way to 35%. The most effective bleaching using carbamide peroxide for at-home bleaching trays is 10%. Okay, that's kind of your golden number right there. Again, this is extracted from many, many studies. And when we see this, this is very valuable information for the clinician. And so when comparing hydrogen peroxide to carbamide peroxide, they looked at the change in color or change in shade guide units. They looked at tooth sensitivity as well and gingival irritation. And what they concluded was that when comparing hydrogen peroxide to carbamide peroxide, change in color was slightly better when using carbamide peroxide. Okay. When it comes to tooth sensitivity and gingival irritation, both of them were equal in terms of that outcome. Okay. And so that was very, very important to keep in mind. Now, there's some important notes and tips to take home here from this specific technique. First of all, the whitening tray should be worn at night, minimum 2 to 4 hours if it's used during the day. Okay. The length of treatment varies. It averages between 2 to 6 weeks. And, you know, I can tell you that most of my patients, if they don't have heavy discoloration, I kind of put them in a 3-week regime, okay, to follow the at-home bleaching. So kind of the golden period here is between 2 to 6 weeks. The teeth lighten to a certain shade and then plateau because some patients become obsessed with this and they want to keep on bleaching. And so if you monitor your patient at a follow-up and then the following visit, you see kind of a same shade, no enhancement, it kind of plateaued. So that means it's not going to get any better. We're using the same method that the patient has been using before, okay? And then you want to wait 2 weeks so that the color stabilizes before any restorative work. And that also applies to bonding, which I'll talk later a bit towards the end. But the color is very important to stabilize, and you want to wait 2 weeks before, if you're doing any shade matching for any direct or indirect restorative work that is within the aesthetic zone. And so these reservoirs may reduce sensitivity and needed with sticky materials and to allow complete seating of the tray. And you can see that what's recommended is when you have your cast, you can place some wax on the facial surface, creating that little space for the gels to flow into that space and ensure that it's properly placed right over the facial aspect of the tooth structure. So that does help versus a tight fitting tray that probably sometimes when you're using a higher viscosity of a material that it will not flow as easy as we would like it to be. And then therefore it will lead sometimes to some areas not receiving the bleaching agent. And then you'll see some patches on the facial surface of the tooth. And a scallop design prevents the tray from contacting the gingival tissue and causing irritation. And that's something that has been recommended to do. However, that's mostly for the maxillary tray. For the mandibular tray, a non-scalloped tray eliminates the tongue and lip irritation and maintain material in the tray better than the mandibular arch. So if you're going to scallop, this is again based off of some of the experts. It's been recommended to scallop the maxillary arch only and leave the mandible, so to avoid sometimes those sharp edges from irritating the tongue and irritating the tissue, and it keeps the material better in place. That's kind of a recommendation from one of the experts that I have adopted here. And so, you know, because there are a lot of products out there, you know that there are some products that have received the ADA seal of acceptance. Basically what that is, it is a voluntary program that some of the manufacturers enroll in to have their product properly assessed and researched by the ADA. So if it is of more comfort to you to guide your patients to use something that has been properly vetted by the ADA, I would look at the seal of acceptance from the ADA on some of these products. And so for 10% carbamide peroxide, you can see these are some of the brands that are that are listed here. There are probably many more that have been introduced over the last few years, but the bottom line is, when you see an ADA seal of acceptance, what it means is that it's just been properly researched and vetted through the ADA, if that makes you feel any, add any more comfort to your decision making, okay? So for at-home bleaching systems, we just talked about the dentist supervised products. Let's move along into the over-the-counter products. And this is where a lot of the confusion happens. We can see here we have the gel in trays from a pre-filled disposable tray. And what has been introduced into the market is really 10% hydrogen peroxide that is advertised to use from 30 to 60 minutes for 5 to 10 days. And also we have 15% hydrogen peroxide, which is used for 15 to 20 minutes, also for 5 to 10 days. And so the best way to understand whether this works or not is to look into the literature. And, you know, there's been a lot of folks that have done extensive work on this. And so here is a very nice randomized clinical trial that I wanted to share with you that looks into the pre-filled disposable. Specifically, 25 patients received 10% hydrogen peroxide. They were used for 30 minutes for 14 days. And then 25 other patients used 9.5 carbamide peroxide as indicated by the manufacturer, 8 hours per day for 14 days. And then they added another group, which is 10% carbamide peroxide, which I really didn't understand what the purpose. It's only a 0.5% difference, but I guess it was just a product comparison if I'm guessing correctly here. But 25 patients received that for 8 hours a day, 8 hours per day used for 14 days. And what they were looking at the amount of color change, how it was accepted by the patient, tooth sensitivity, and gingival irritation. And so for color change, what they found was that they were similar at 7 days and at 14 days. Greater reduction in the yellow hue at 14 days, but both techniques were pretty much the same. However, they were all highly accepted and effective as when they were surveyed with these patients. In terms of tooth sensitivity, mild tooth sensitivity with time, regardless of the concentration or the application time. Okay, so they all pretty much performed the same here as well. And gingival irritation, localized gingival irritation was observed in both tray methods. And so what I really wanted to highlight here is that if you had doubts about these pre-filled disposable trays, if you take a look at how they are being applied and how they're used, they're pretty much similar to the custom-made ones that are made at the dentist office. But, you know, and they're more affordable as well. And so, you know, a lot of us as clinicians, you know, we might kind of steer our attention away from that, and we want to do something that's more internally made, and, you know, it is more cost to the patient. And so we have to think of what really benefits the patient. Some patients don't have the ability to really afford a supervised at-home bleaching or cut from a custom tray. And so directing them towards these products can be of good use and useful to the patient, because you can see that the outcome is very similar in terms of its whitening effectiveness and in terms of the tooth sensitivity. How about these whitening strips? Okay, the whitening strips, they are basically 10% carbamide peroxide. The whitening strips were introduced in the year 2000. Basically, they are adhesive strips. They release 5 to 14% hydrogen peroxide, again, depending on the manufacturer, and they're applied for 5 to 60 minutes. Again, depending on the concentration. So it's very important to follow the recommendations made by the manufacturer. And they've been recommended to apply them 1 to 2 times per day, up to 28 days, okay? And so the only way to understand whether these work or not is to look into folks that have done clinical research. And when this is a nice review that looked at multiple studies that evaluated the effectiveness of whitening strips compared to a gel in tray method, or the custom-made trays. And you can see here that they're comparing these two using 10% carbamide peroxide. So 8 randomized trials were included in the study. Again, looking at the same parameters, change in color, acceptance, tooth sensitivity, and gingival irritation. So when it comes to the lightness, change in lightness, they were pretty much the same. And I was quite surprised to see that. So both products were effective in terms of enhancing the value of the tooth structure. In terms of reduction of yellow, the white strips were actually better than the gel in tray. And again, this is based off of the 8 studies that were reported in this review. Tooth sensitivity was pretty much the same. Okay. And the gel in trays, the trays had more gingival irritation than the whitening strips. And you all can imagine that's why. So it's very important to point out that the quality of evidence generated was very low for all outcomes. Why? If you look at the clinical trials that formed the systematic review, most of them were supported by the manufacturer. You can't help but questioning the bias involved. And actually, in this review, the clinical trials were evaluated to be of high bias. So you have to be very careful. Any systematic review you read in the literature is only as good as the clinical trials that comprise it. And so if you have poor clinical trials, ultimately it's going to lead to a poor systematic review. Because, as academician, we always are excited whenever we see a systematic review published in any of the journals. And it's very dangerous when you read the aim and you read the conclusion. And so that can be very, very misleading. And so that's why, I take the time to really look into that detail and translate it and interpret it to you, hopefully to make the best or the most out of it. And so what they concluded is that there was really no sound evidence to recommend the white strips versus the gel in trays, okay? Despite that, the favorable outcome from the white strips, again, it was not based on sound, solid evidence. However, you start questioning and you start wondering, this procedure might actually work. And a lot of the researchers that have shown it does enhance the value of the tooth structure over time, okay? And so one thing to keep in mind also here, if you're trying to direct your patients to these, is also how the cost can add up, because you're using a lot of them over a longer period of time. So you might actually end up paying a lot more than if you were to do something that was dentist supervised. So that's just something to keep in mind. And actually, I haven't had the chance to do the math, but that's something that I can see a value of adding as well, considering the ideal times for using both methods. And so here's another nice study that's comparing the pre-filled trays versus the white strips versus the custom-made trays. And they all use 10% hydrogen peroxide, and 60 patients were enrolled. It was a single-blind, parallel randomized clinical trial, and that's how these clinical trials should be reported. They used for 14 days with a 30-minute per day requirement for use, and all systems showed similar whitening after use. And so the strips and the pre-filled disposable trays produced lower sensitivity, intensity of tooth sensitivity compared to the gel in trays. So again, you have to interpret this with caution, but you can see that these whitening strips, when they're used correctly, the pre-filled gel in trays also can be effective and they can work, okay? But again, your patient is also going to need that guidance from you, and I think that's very important to keep in mind, okay? The pre-filled tray produced lower risk of gingival irritation when compared to the conventional, and that's really understandable. So moving along to more of these over-the-counter products, we have paint-on gel or varnish. Basically what it is, it's a hydrogen or carbamide peroxide in a suspension that is brushed by an applicator over the tooth surface. And so the pros of these are really, they're easy to apply. Of course, less gingival irritation, there's no gingival contact. The cons, it has less contact time with the tooth structure because there's nothing that's holding it in place, less whitening efficacy, and these reusable tips can also lead to contamination. So again, there are products out there, they're heavily advertised to the patients. I think it is our responsibility as clinicians to provide the proper guidance to our patients. And then we have these whitening toothpastes. And basically the whitening toothpastes are just abrasives and detergents that have been added to the toothpaste formula that enhance the mechanical biofilm removal. It includes low concentration of carbamide or hydrogen peroxide so that it can add that whitening effect. And so to look at some of the research that's been reported out there for using these whitening toothpaste, you can see that the whitening toothpaste are, this is a study that, or analysis actually, the question was, are the whitening toothpaste as effective and safe as regular and other home, regular toothpaste and other home-based products? And they wanted to see the effect of application time on the whitening efficacy. So you can see they compared whitening toothpaste to a regular toothpaste, to paint-on gels, and to whitening strips. And I thought that was very interesting. That was a very interesting comparison. And so when it comes to comparing the whitening toothpaste to a regular toothpaste, of course, the whitening toothpaste is going to reduce extrinsic stains and has more of a whitening effect compared to a regular toothpaste. However, it is more abrasive, and that's a concern that it might have with excessive use of it, of wear on the natural tooth structure. So there are more adverse effects that have been reported when using the whitening toothpaste. How does the whitening toothpaste compare to paint-on gels and reducing extrinsic stains? And so they were both equal in terms of that outcome. So whitening toothpaste compared to paint-on gels had similar whitening effects and also similar adverse effects. Okay. When it compares to the whitening strips, of course, the whitening strips have a better ability to whiten the tooth structure compared to whitening toothpaste. Okay. And they both had similar adverse effects compared to when comparing the tooth. So caution is recommended when interpreting these conclusions because they are impacted by the low quality of the primary studies, most of which are sponsored by industry. And I really, wanted to highlight that it's very nice of the authors to report something like this and in bold, and that's really important because our literature is really full of studies that can be very misleading, especially when it comes to use of specific materials in our work. Okay, so moving along with whitening mouth rinses that are available to us. Basically, they have a low concentration of hydrogen peroxide, just around 1.5%. It protects the teeth surface from new stains if you use it regularly. And so they're around and they're available over the counter. And we always get questions from patients, is it, can we use them? So there's really no adverse effect to using them. Basically, the addition here is hydrogen peroxide in the mix, and it's a very weak concentration, but swishing it around in the patient's mouth over time, multiple use may have or may maintain a little bit the discoloration of the tooth from happening. We also have whitening floss that is available, and basically it contains silica in the composition, and they lead to stain reduction around the interproximal and subgingival areas, areas where if you are using a whitening strip or sometimes the whitening strip is not easy to place interproximally. And so using these whitening flosses have been advocated to help remove some of the extrinsic stains from interproximal areas. Again, these will probably become useful if they're used over and over. And so I don't know how practical it is. And that's why there's really not a lot of research out there comparing it in a trial or so. But they are products out there, and they are claimed to have a whitening effect. And again, your patients might come in asking you about these products. Okay, folks, so now we've talked about the at-home bleaching system. We talked about the dentist supervised and then also the over-the-counter. So let's move along to talking about in-office bleaching systems. And most of you have practiced this or used in-office bleaching system. It is basically a concentrated hydrogen peroxide, usually of 35%. So that is a very high concentration of hydrogen peroxide. You must use the tissue barriers to isolate the gingiva from contacting with the hydrogen peroxide. And of course, this is supervised, and it is done in a short period of time, between 30 to 60 minutes in the office. And sometimes it is not done by one visit. It requires 2 or sometimes 3 visits to achieve the whitening that you and the patient are striving for. How about the use of lights? And boy, this has been an area of controversy for many years, okay? But I think the literature is clear at that, and expert opinions are also clear at whether we should use the light to enhance the effectiveness of the in-office bleaching system. The concept is that the oxidative action is sometimes supported by irradiation with a heat lamp to enhance the oxidative action. So what is really happening here is that the heat generated from these lamps, like I mentioned before, can enhance the chemistry and the effectiveness of the bleaching agent. Okay, so the area of what is it called, photochemistry, really does not exist. Okay, those have been used really a lot for a lot of just advertising and selling the product. And you know, it does look sometimes fancy when you see them in some of the offices or some of the and sometimes in the mall as well. In the shopping centers, you see these booths where they have these lights and the patient sitting underneath the light. Just gives the perception that the bleaching is going to be further enhanced. And so the ultimate question is here: does light activated in-office vital bleaching have a greater whitening efficacy and higher tooth sensitivity in comparison with in-office vital bleaching without the light? And so again, very nice review, 21 clinical trials that looked at change in color, change in shade guide units, the risk and intensity of tooth sensitivity. And what the conclusion was out of this study when they're comparing the use of light or the bleaching effect without the light, is that activation of in-office bleaching gel with light does not seem to improve color change or affect tooth sensitivity. Okay, so whether you use the light or you didn't use it, it really did not make any difference. Okay, so that's really the consensus, and this is really out of a respected group that does a lot of work and research on bleaching. And so I would take their word for that. But again, if you ask a lot of the experts in this area, they will confirm that, you know, the bleaching efficacy is the same, whether you used it with or without the light. There might be some enhancement from the heat that's generated from these lamps, but there's really nothing more than to that. Okay. So now that we have talked about the different products that are available to us in terms of bleaching, let's see the effect of bleaching on the tooth structure, and specifically speaking here on enamel. And so we know that the enamel and dentin, they're really highly optimized and organic and inorganic complex. Using high concentrations of hydrogen peroxide can be damaging to this matrix, to this complex matrix. And so this is a nice study that looked really at that wanted to evaluate the influence of 5 different bleaching agents with additional light activation on the enamel and dentin surface microhardness and chemical composition. So this is an extensive study, looked at multiple concentrations. They used multiple lights, and they really were not focusing on the efficacy of these bleaching agents. They were focusing on the hardness of enamel when using these different agents along with the different light sources. And so you can see here they use 38% and 25% hydrogen peroxide, 16% of carbamide peroxide for 2 days up to 15 minutes. All bleaching gels were tested alone and in combination with the Zoom 2 light emitting diode, organic LED, and also the femtosecond laser. So just different combinations here. They wanted to see what the worst case scenario can be. And so what they concluded here is that an increase in the peroxide concentration and gel acidity negatively affected microhardness and concentrations of calcium and phosphorus in enamel and dentin. So that's important to keep in mind. High concentration and also the pH of the bleaching agent that you're using. Okay, and what was really important to point out is that, you know, that there is really no significant effect on the microhardness of enamel when 10% carbamide peroxide is used for 7, 14, and up to 21 days. Okay, so that study was really focusing on extreme concentrations and excessive use of light source and heat generated. And so then they found that higher concentration and the acidity of the bleaching agent did negatively affect the microhardness. To be safe, and if you're using at home or dentist supervised at home bleaching, stick with the 10% carbamide peroxide, safely used over 21 days. They found that there is no effect on the hardness of enamel. Okay. And so what about tooth sensitivity? That's an area that is of concern. You get many patients that follow up and say, doc, you know, I'm starting to get sensitivity. What should I do here? And so for at-home bleaching system, 37 to 90% of patients report a mild increase in tooth sensitivity. For in-office bleaching system, 17 to 100% of the patients report a moderate to severe increase in tooth sensitivity. Okay, and so the theory behind the sensitivity is not really clear. Some say that microscopic defects in subsurface pores are caused by the peroxide and therefore it can lead to the sensitivity. Others say that fluid movements within the dental tubules detected by nerve endings near the dentin, they can cause the sensitivity. Regardless of what it is a problem that patients can face during this procedure, and you want to make sure that you are ready to provide the right information to your patient. So, contributing factors to the sensitivity, of course, history of tooth sensitivity itself. You got a patient walking into your practice telling you, hey doc, listen, my teeth are very sensitive all the time. That's probably not a good candidate for bleaching, okay? Patients with gingival recession also is a problem. Pre-treatment shade. If a patient has lighter teeth, they are more likely to develop sensitivity than patients that have darker teeth, okay? And also longer application times are contributing factors, and of course, higher concentration. So all of these factors should be in your mind when you're working with your patient on prescribing for them the best bleaching method, okay? Here's a nice review looking at home bleaching. They want to evaluate the risk and intensity of tooth sensitivity during in-office and at-home bleaching in adult patients. So it was 20 randomized trials that was included. Bottom line was that there was no differences were detected either regarding risk and or intensity of the tooth sensitivity or the effectiveness of the bleaching treatment. So, the tooth sensitivity in this particular review at home and in office were pretty much similar, okay? Pretty much the same in terms of risks and intensity. Again, it really, really depends on the regime that the patient is following, depends on the concentration. All these are factors that can, of course, lead to increasing the risk for tooth sensitivity. So again, if you are faced with this problem, there are preventive measures that you can do before even considering the bleaching process. One of them is a shorter application time. There are some products that have some additives like potassium nitrate and hydroxyapatite. These additives have shown to help in terms of the issue with sensitivity. And then also recommending desensitizing toothpaste has been also advocated for. As a passive approach for treatment of the sensitivity, simply discontinue treatment for 24 hours. That can help. Reduce the frequency. Ask the patient if they call in and they tell you that I'm experiencing this sensitivity, go ahead and tell them to do so. Reduce the application time also. Consider doing that. So frequency and application time. And of course, the active approach to deal with this, if a patient walks into your practice is using some of these desensitizing gels, they can be very helpful when a patient walks into your office complaining from sensitivity due to excessive use of the bleaching agent. So now that we've kind of understood the effect of bleaching agent on the tooth structure, let's take a look at the effect on materials. And so really there is no effect of any of the bleaching agents that I talked about on ceramics, on alloys, and on amalgam. And there are imperceptible color changes in composite restorations. However, higher concentrations might reduce the hardness of the composite surface. So if you have a lot of composite restorations, enhancing the bleaching or the color of the composite is not really going to happen. Okay. But if the patient is using them and in some areas and the bleaching agent is sitting on that composite for a longer period of time, that composite can, the surface can be affected. And of course, when you're decreasing the hardness of the surface is becoming rougher, more liable to staining and also plaque accumulation. So these things you have to keep in mind and during the assessment of the bleaching process. And we have confirmed through a lot of research that there is a definite effect on enamel and dentin bonding. So it's been advocated to wait 7 to 14 days, preferably after the bleaching has ended, to do any bonding procedure. So I mentioned this before. Also, if you're waiting for tooth color to stabilize, I would recommend 7 to 14 days for the tooth color to stabilize. But if you're going to do a bonding procedure, it's also recommended to wait 7 to 14 days. Then the bond strength to the tooth structure is going to be optimized once again. And like I mentioned before, after 6 weeks of bleaching, if there's no improvement, really it's kind of determined that the tooth has reached to its end point and it's not going to change after that. I thought that was worthwhile repeating. How about these dark stained teeth? And I think this is wrapping towards the end of the presentation here. We have patients that walk in with heavily dark stained teeth. And some of them, for example, have due to certain antibiotics that they've taken over their time period. And so what can you do and what's the regime to follow to achieve an outcome that can be more favorable to these patients? And this was a case that I did not too long ago. And I get about 3 or 4 of these cases walking into the practice every year. And so what we know so far is that the clinical trials show whitening times beyond the 2 to 6 weeks, the traditional 2 to 6 weeks. Some of them have recommended that bleaching should be extended up to 6 months in order to achieve a favorable whitening of these dark stained tooth structure. And then with the discoloration, now this is important to do when you're in your DXD appointment. If the discoloration is at the neck of the tooth, where you see that dark gray or bluish hue, that has pretty much a very poor prognosis for outcome, okay? So that's the time where you tell your patient, listen, let's look into other methods for whitening your teeth, and that can involve direct or indirect restorative procedures, because I don't think you investing the time and money on bleaching is going to reach a favorable outcome. And the patients that have these dark stained teeth and they've used bleaching agents for an extensive period of time, they have seen some degree of lightness in the color. But you know, that promising that they will disappear, will go away, it cannot be made to the patient at all, okay? So some lightening will happen, but it will not disappear. This is a nice study that looked at randomized controlled trials of at-home bleaching of tetracycline state teeth. They investigated the effectiveness of 2 home bleaching modalities on whitening of tetracycline teeth. They used 15% carbamide peroxide in a tray and 6.5 hydrogen peroxide as strips. They used it over a 3-month period. The 6% hydrogen peroxide strip performed equally as well to the 15% carbamide peroxide tray. So again, this is more evidence that that the pre-filled trays and the whitening strips, they're performing favorable in the literature, okay? And so this was kind of important to report, because we have these patients that do walk in, and if you can get a lighter color out of it, and that's the patient's expectation, absolutely fine to go ahead and try. But again, it's going to take longer than the 6 weeks. So it's probably looking at 2 to 3 months, and some have done it up to 6 months. But no promises should be made to the patient that the teeth will become lighter, okay? And so, folks, I'd like to wrap this this presentation with a few conclusions here. We've learned that at-home bleaching is safe and effective, especially when it is directed by you, the clinician. You should be able to provide your patient with with guidance and direct them to using a specific concentration for a specific amount of time, and just kind of keep them in that monitoring phase. There is negligible effects on enamel and other materials. However, concentration and acidity plays an important role into that. Some of the over-the-counter products are more effective than others. And so, you know, we saw some of these whitening mouth rinses and varnishes and gel. You know, they don't have a way of securing the close proximity of the bleaching agent to the tooth structure. So I really wouldn't recommend them. And then the in-office bleaching is effective without the light. Okay, so don't get caught into spending or investing a lot of money into buying the light. It really adds no benefit. And finally, the gold standard is dentist prescribed and patient applied. And I think we can all agree to that. And the literature has shown that over the past 30 years that this can work. But again, it's very important to know what type of bleaching agent it is, what the concentration and the acidity of the product, and to be able to diagnose the case before directing the patient to what system to use, I think are very important take-home messages. And folks, by that, I would like to thank you all very, very much for your kind attention. Thank you.
Thank you, Dr. Sulaiman. That was fantastic. That's one a webinar we're going to share with our staff when we get back and get everybody on the same page. Obviously, this is a popular topic. We've got 63 questions. So
Wow.
for those of you that have been watching, would you upvote on your favorite questions? Because there's no way we're going to get through all these questions. And, you know, I know you hit a lot of these points, but I will read the questions, even though they were in your conclusions, and just will get to them as quick as possible. Okay,
Yes.
so number one question. Can pregnant women whiten their teeth?
You know, I have, you know, again, looking at these studies in the literature, there's no clear consensus on that pregnant women should not. But again, if you think about it, it just makes common sense. You're using chemicals, okay? And during pregnancy, you want to stay away from chemicals as much as possible. So during the 9-month pregnancy, I think focusing on oral hygiene measures other than whitening is going to be recommended, you know? You know, I've seen some that say, absolutely not, you should not use it. Others would say, no, it's fine, especially in low concentrations, doesn't cause any harm. But again, you know, common sense really plays an important role here. I mean, is this pregnant woman is it a matter of life or death, whether she whitens her teeth or not over her pregnancy period? So I think common sense is really gonna play an important role in the decision-making here.
Now, would you be concerned with the peroxides leaching anything out of our dental materials?
No, there's no, because even though that, you know, with in-office bleaching using a high concentration of peroxide, it's still lower amounts that there's no concern. Again, the only thing that was a concern was the possibility of decreasing the hardness of composite resin surface. No effect on others. And so nothing has been reported in the literature concerning that, but there's negligible effects.
Okay. Would you set a minimum age for bleaching?
Oh boy, that's a tough one. Again, I use common sense here. You know, I mean, I've seen patients in the teens that have been, recommended to use bleaching. But again, you know, the younger the patient is, the thicker the enamel is, the outcome is different than treating patients that are more senior than that. And so really it has to do with the, I don't think there's a strict age limit here for the bleaching, but you know, I mean, for me, if somebody's coming in, you know, 15, 16 years old and they needing that, and they understand the concept of taking care of their mouth first and foremost, and they have good oral hygiene, and they wanted some lighter teeth, I don't think there's anything against that, assuming that your patient understands what's going on and how to strictly follow these directions, because you can see that bleaching can be abused by the patient especially if they don't follow up with their clinician. So that's the worry. More mature patients, of course, and adult patients, we would assume that they would follow directions more carefully. So, but again, there hasn't been any strict scientific age limit for bleaching teeth.
Under what situations would you say bleaching is contraindicated?
Well, I mentioned some of the limitations. Of course, patients that have a history of tooth sensitivity, gingival irritation, patients that have tetracycline stained teeth, with stains that have these darkish blue, gray intrinsic stains. These are very hard to bleach. So these are some of the contraindications, not because the patient can't use them, it's just because the outcome is not going to be favorable. And so that's really, those are the limitations. Other than that, this is a relatively safe procedure if it is closely monitored by and directed by the clinician.
Okay. I know the answer to this, but are whitening lights recognized as gimmicks at this point in time?
Yes.
Okay, thank you.
I think I explained that thoroughly.
You did. But it's a popular question. So
yes.
What is your general protocol that you use for bleaching?
Of course, Haywood and Hyman at UNC, right? So this is in our blood. This is when we're doing it, we follow the recommendation of that was made since then. Basically, using 10% up to 15% carbamide peroxide with custom made trays. We do. Trim the trays around the gingival margin for the maxillary, keep the mandibular arch as is, and then create these reservoirs by adding these wax on the facial surface. It just allows for a generous amount of the material to be properly localized over the facial aspect of the tooth structure. And so checking the fit of your tray is going to be very important. When the patient comes in, also checking the fit, making sure that it doesn't impinge on the tooth structure, and the gingiva is also something very important, because the patient's going to be wearing this for the next 2 to 4 weeks at least. And again, using that concentration for an average of 3 weeks, and then we recall them back in. I've taken photos before, and I take them after using the Vita bleach guide, and we can see the progress. And if the patient is happy, I'm happy, and if the patient wants a little bit further, I can say we can give it a try. Let's try for another week, but there are no promises. They come in, if it's enhanced and we're happy, that's it. If it's not enhanced, I tell them, sorry, that's about the limit there. But I think it's very important to spend that time with your patient before doing anything related to bleaching, to make sure that all patient question is addressed, and so that no promises should be made really until kind of giving a patient a low expectation, but then showing them a nice result at the end is going to mean a lot to the patient.
Do you have any research for charcoal toothpaste having damaging effects?
Yes, we just published, this is something I talk about in my ceramics lecture. So in terms of adverse effect on natural tooth structure, I think the literature is available out there. You can see it really depends on a lot of factors. One of them is, what is the RDA value of that tooth, which is the relative dentin abrasivity of the toothpaste, and what toothbrush technique is being used, the pressure being applied. So there's a lot of variables to that. Some will say that it has no effect. Some will say, yes, it does. It really, just stand right in the middle. Again, it's just common sense. Reusing a toothpaste with a high RDA value is going to be more abrasive. And if you're using extreme forces, again, that's going to exacerbate the wear or the effect it can have on the tooth structure, and the damaging effect it can have to irritating the gingiva. However, we did also look into the effect of stains and glaze on the of ceramic material, and I can just share with you that the bottom line, this is going to be published in the Journal of Aesthetic and Restorative Dentistry over the next month or so. But we did determine that the color of the ceramic over a 5-year simulation, toothbrush simulation study, that using an abrasive toothpaste can change the color of a ceramic material, whether it was feldspathic, lucite, lithium disilicate, or zirconia material. And the glaze does wear off with time, and it does wear faster when you're using an abrasive toothpaste. So this is a lot of sensitive things. You know, when you have a patient walking in there and he has a single central that's you know, an indirect restoration, regardless of what type of ceramic it is, with brushing, using these abrasive toothpaste, that ceramic can change with time. And so then now you're stuck with a tooth that doesn't really match the adjacent teeth like it was when it was initially placed in the patient's mouth.
Okay, we had a doctor that had a tetracycline patient. They tried the core whitening system, KOR, and said the results did not meet their expectations. Any thoughts?
My question is, I'm not familiar with the product in terms of concentration. I mean, was it an in-office bleaching system? Was it an at-home bleaching system? What was the concentration used? Was I'm assuming a customized tray was made at the clinician's office. But you know, I don't know the concentration, and I don't know the time period as well. And so, you know, these are all factors that we have to understand. So again, if you're monitoring this case, you can see along the presentation that concentration and time has an important role, specifically when you're talking about dark stained teeth. And so when you're monitoring a case for a tetracycline stained patient over a month and a half, 2 months, and you're using a specific concentration, you see no progress really, maybe increasing the concentration and following up for another month, you can see that it has been kind of okay to do up to 6 months with heavily dark stained teeth. And so again, it's your responsibility as a clinician to start with something. And if you have the ability of increasing the concentration, increasing the application time, keeping a very close eye on the patient, having them come back every week or 2 weeks and monitoring it properly, because looking at a shade guide and just by the eye is not enough. You must use that bleach guide that I showed you and take a very nice photo. The light settings of the photo should be standardized, because this is a comparison. This is something that you visually have to compare under the same environment, okay? So I wouldn't take a picture for the patient in the hallway once and in the chair another time and then compare between them, because the light has a very important role to play here. That's why all these studies, they had to do strict standardization to report these numbers. And so if you're a dentist that is following up with a case for bleaching on a heavily darkly stained tooth, please make sure that you document your case before starting and along the way. That's the only way that you and your patient are going to be able to understand the progress.
Thank you. Do anti-sensitivity agents interfere with the bleaching process?
No, they don't.
Okay.
No, they don't have any significant effect on the process. But again, it's just a matter of whether you're discontinuing the treatment or you're continuing after using the desensitizing agent. And another evidence of that is some have been incorporated already into the bleaching gels. So I wouldn't expect any effect.
Okay. What is the optimum protocol to reduce sensitivity? And they list out here using MI paste gel in the tray 2 weeks prior and 2 weeks after whitening.
That's I think using that's a fairly extreme protocol to follow, using it using MI paste. I've never seen any of the reported methods in the literature of using the at-home bleaching system that would advocate the use of these desensitizing agents before the treatment. You know, it's a matter of whether it's going to happen or not. Some patients have very mild sensitivity, others have a little bit more moderate, and the severe ones, bringing them in and applying desensitizing gels in office, discontinuing the treatment for a little period of time has kind of been more advocated than these very strict protocols that just prolong the treatment and complicate things. But again, you know, clinicians should assess each case independently on and you know, and they should use their common sense on whether to decrease concentration or decrease time application, discontinue treatment, and so forth. So again, you know, use your common sense. As long as you understand what the process is, you understand how to treat it, you're in good shape. So you don't have to worry about anything.
Is there any link between bleaching frequency and oropharyngeal cancer in the literature?
I am not aware of that.
Okay.
I am not aware of that. I don't know.
Okay, can you expand on, again, why the 10% carbamide peroxide was presented as the optimal concentration versus other concentrations?
It's just a matter of effectiveness, the efficacy of it. You know, how, you know, through the literature, you can see that it was used from 5% all the way to 35%. And so sometimes using the 35% had the same outcome as the 10%. So why introduce a higher concentration? So 10% really is just based off of the literature, a lot of the studies, consensus of the expert. When you review all these studies, and there's been tens and tens of studies that have been done on bleaching agents, you'll reach to a common conclusion that why are you increasing the concentration when you don't need to do so? So 10% carbamide peroxide is kind of the golden number here.
Can you comment on diet modification during the bleaching process?
Well, you know, I think it has to do with introducing stains. You know, I mean, if your patient is going to bleach their teeth and they're a heavy, heavy coffee drinker, you would want to modify the patient's habit first. You know, having any dark stained food or beverage is going to affect the process and affect the outcome. Right? I mean, how would you expect to reach to a nice outcome if your patient is continuing to use the same factor that led to the discoloration in the first place? So again, it's just a matter of educating your patient, raising that awareness. Some patients will tell you, forget it, doc, I'm not gonna, you know, I'm not gonna, you know, stop drinking my coffee because I want to whiten. And some will listen to you. So, you know, of course, these are factors that can affect the outcome. And so that's why a lot of these studies really had patients that were selected. And so that's very important to point out. You know, this is the ideal world of clinical trials in dentistry. Everything is really, you know, in an ideal and optimum scenario, right? And sometimes these do not exist in the real world. And so that's why it's important for us to interpret these, you know, these results to the clinician, trying to, you know, remove all this bias and remove all these factors that can affect the outcome and can mislead the clinician to using the wrong material or wrong method.
Okay. Does bleaching frequently reduce the enamel in teeth?
No. Yeah, I mean, you saw the multiple concentrations where yours barely affect. High concentrations of bleaching agents might decrease the hardness a little bit of the surface, and this was very negligible also. But 10% carbamide peroxide, 15%, you know, these are very low concentrations. They have shown to have no effect on the enamel.
Is bleaching recommended for high caries risk patients?
High caries risk patient. You know, I mean, you know, to me, a patient has a lot more to be worried about, and also the clinician focusing on that, right? I mean, controlling the caries, of course, of the patient is going to be the first and foremost to focus on. And then comes the bleaching. I think that's the end stage of after the control phase has completed. Depending on the amount of composite work you've done on the anterior teeth, if there's a lot of natural enamel still left, of course, then putting a patient to the bleaching process there is going to enhance and maybe encourage the patient to take care of the teeth further. But you know, I wouldn't assume somebody has a lot of caries and say, hey, well, here you go, start with the bleaching process. And I mean, bleaching doesn't arrest caries, so I don't think it's a matter of controlling the caries first and then using bleaching to promote the oral health of the patient and to encourage patient to take care of their teeth.
Okay. Is there any regimen to remove white spots effectively?
Yes. Well, boy, that's a whole different topic to talk about white spots.
Yeah, it is.
Very simply put, white spots depend on the depth of the white spot. Okay. And don't ask me how that's measured. It's very difficult. Transillumination has helped, but there's no clear way to evaluate or to assess how deep a white spot is. But some of these superficial white spots have been successfully removed through a micro or macro abrasion. Whitening will actually highlight the white spots even further. So that's not going to really help. And also resin infiltration. So these are very conservative measures that have been taken to eliminate superficial white spot lesions on the tooth surface. So I've done many cases of those. I've been using resin infiltration like Icon has been very helpful to eliminate a lot of these white spots. And, you know, again, that's a whole different lecture that I have, you know, talking specifically about minimal invasive dentistry.
Okay. For anterior aesthetics cases, full mouth rehab, what is your protocol for whitening in regards to time frame before prepping teeth?
So yeah, like I said, you know, if you're deciding to do any restorative work in the anterior zone, you want to make sure that if the patient is not satisfied with the color of the teeth and you are putting them in a bleaching regime, you want to make sure that after you have reached the final outcome or the final shade where the patient is happy, where you're going to tell your patient, now I'm going to make my direct and indirect restorative work similar to this shade. This is where you have to wait 7 to 14 days for the color to stabilize. And it's not just for the color to stabilize, it's also for bonding, direct bonding to the tooth surface, okay? To be safe, I would recommend waiting 2 weeks. I think that's a very good amount of time for the color of the tooth to stabilize and to ensure that proper bonding to the tooth structure can be accomplished.
Okay. Have you tried using desensitizing gel from the whitening kits with any success?
I have not, no, because I haven't really recommended them a lot. You know, the cases that I get, I use the custom-made trays for at-home bleaching. And they do come with a desensitizing gel. I just haven't really looked at what the composition of the desensitizing gel is. I'm assuming it's safe. If it's an over-counter product, I'm assuming it's safe to use. And so it's one of the things that if your patient is, you know, experiencing mild to moderate sensitivity and that is available for them to use, just say you can encourage them to use it. Discontinue the treatment for 24 hours. But if it is, you know, if it's more severe than that, then it's something that you might want to call in your patient to your practice to take a closer look at it. But I have not seen what the composition of the desensitizing gel and these pre-filled trays are. But I'm assuming they can be effective in mild to moderate cases.
Okay, well, we're getting at about an hour and a half here. So what I'll do is just kind of pick 3 more questions here, and we'll call it a day with that. I'm sorry we couldn't get to the remaining 67 questions. Okay, what product would you recommend for laser diode bleaching? I throw that back at you just so you can say it again.
No product I would recommend for laser diode bleaching. I look at the bleaching. I look at bleaching products based off of their concentration, and I look at the time indicated for use. I look at the ADA seal of acceptance, knowing that this has been vetted somewhat through the ADA, through voluntary research that's been done. Manufacturers have invested more time into it, and I can care less about what light source is being used.
Okay. What does research conclude regarding internal bleaching and, or pardon me, what does research conclude regarding bleaching and internal resorption?
So the area of internal tooth bleaching, or the area, I've kind of left that to the endodontist to look at and to cover. I have not dug deep into it, so I don't want to provide an answer that I don't know the accuracy of. So I don't know an answer to that.
Okay, and let's see. A lot of whitening lights, all. Okay. What do you think of using fluoride varnish after in-office bleaching? I was told that it will prevent post-operative sensitivity.
Absolutely. I mean, you know, it's any of those agents will help in reducing the sensitivity. Some dentists decide to apply that instantly, you know, after in-office bleaching because of the high concentration of hydrogen peroxide used. There's nothing against that. It's just a matter of whether your patient will experience sensitivity or not. It differs from patient to patient. If you want to use it just to be on the safe side, there's absolutely nothing that contraindicates that.
Alrighty, with that, you know, I think all we have to do is say thank you. It was wonderful. We've got lots of people writing in the chat and the Q&A. They would like you to come back and speak on other topics. So who knows, depending on how this mandated closure goes, we might have you back another time, Dr. Sulaiman.
Sure, absolutely. My pleasure.
This has been fantastic. I am going to share my screen now and just allow people to see what upcoming webinars are going to occur over the next few days. We've got 3 tomorrow, starting with Dr. Michael Fling in the morning and going throughout the day. So let's bring up that. And a reminder, you can find out what webinars we have on washingtonagd.org. For those of you that came into the webinar late, yes is the answer regarding whether these webinars will be available online. They will be put up on YouTube within the next day or so, and you can see those at Washington Academy of General Dentistry on the YouTube channel. All CE here is free on these webinars, and all these webinars, the presenters have donated their time. So we thank them very much for contributing to the Washington Academy of General Dentistry Stay Home, Stay Healthy CE. For those of you in Washington State, we've got lots of webinars coming up with our local CPAs, practice management firms, and Harris Biomedical that will really speak more to the Washington State dentists than maybe some from out of state, but not necessarily. If you have somebody that you would like us to approach to give a webinar, please send their name to info@washingtonagd.org. We'd be happy to reach out to them. Over the next couple of weeks, Dr. Yassine is continuing his implant study club, and next time he meets next Wednesday, Dr. Catafucci will be joining him, not to be missed. Again, thank you to all our friends in Canada, the Canadian Academy of Restorative Dentistry and Prosthodontics, for joining us. Over the last week and a half, we've had over 1,300 Canadian dentists log into these webinars. So thank you. We appreciate you joining us. CE credit will be mailed out in the next couple of days. Look for an email coming from the University of Washington School of Dentistry, CE department. For those of you that are AGD members, we will report your credits to the Academy of General Dentistry. It should show up on your transcript within the next couple of weeks. Use the QR codes that are available on these flyers to register for upcoming courses, or go to Washington Academy of General Dentistry.org. So that's WashingtonAGD.org to register for future webinars, seminars. We also do have some existing courses that are not free CE events, but please take a look at those as well. We've got a nice cone beam CT course on this Thursday with Dr. Timothy. That's an 8-hour course. If you're interested in that, you want to get registered as soon as possible, simply so we can get you the information so you're ready to go with reviewing cone beam CTs and have the software and that prior to Thursday. For dental students, mark on your calendar, August 15th, we continue with our Preparation 101 course from analog to digital. We look forward to doing that. And as I mentioned, Dr. Michael Fling tomorrow starts us off at 10 a.m., the upper anterior segment. You're going to like that webinar. Deborah Engelhardt Nash, keeping your teams and patients engaged when you're not in the practice, is at noon tomorrow. And then we're following up at 2:30 with Dr. Michael Giardino, diagnosis of periodontal and peri-implant diseases and conditions. This is a look at the new updated classification system. So that's a good one to have your hygienist, your front desk, and yourself to watch and put that into perspective. Monday, we've got Dr. Nash. She's going to present on indirect aesthetic dentistry. and on and on. So with that, I'd just like to say thank you again to all our sponsors, Canadian Academy of Restorative Dentistry and Prosthodontics, Comet USA, Patterson Dental, Pierce County Dental Society, Snohomish County Dental Society, Seattle King County Dental Society, the University of Washington, Department of CE at the School of Dentistry, and again, the Washington Academy of General Dentistry. From the Washington Academy of General Dentistry, we want to say stay home, stay healthy, and please enjoy this free CE. Thank you, Valerie.
Dr. Hess, once again, for managing all this great stuff. And I just got a personal text from Dr. Poor that asked, are we allowing people to write reviews on our social media about all the good work that we're doing here? And the answer is absolutely yes. Please, we would love to see reviews coming in and encouraging your colleagues to register for these events. So thank you for the question, the personal text of thank you. And Dr. Hess and Dr. Hayamoto now are aware that we will remind people to do that. So thank you so much.
All right, Val, just put that in the list of things we've got to say each time, eh?
Thank you, Dr. Sullivan.
All righty.
Thank you very much.
Thanks, guys.
All right. Thank you.
Val, I think you can take us out.